All right, good morning, everybody. This is Health Talk, and we are privileged to have with us here in the studio John Bleicher, and he is the trauma coordinator with Providence Health and Services, Western Montana. St. Patrick Hospital there, of course. And first of all, John, good morning. Welcome, sir.
Good morning. Nice to be here. Thank you.
How are you?
I'm good.
All right, tell us a little bit about John Bleicher.
I'm retiring in 3 weeks.
Oh,
That's
sure.
The most important thing.
Okay. Just rub it in, would you?
Married, have a daughter, have been involved in emergency services for 34 years. Started as an EMT in a small town, Boulder, Montana. Signed up.
I know it well.
Okay. Yeah. Just signed up for the local ambulance service and took the EMT course. Had no thought of it turning into a career. Did it for other reasons. Kind of got the bug. And next thing you know, I'm off to nursing school. So I've been a nurse and a paramedic, and I worked in the ambulance, and I taught paramedics, and I started the area backcountry medicine school with a friend of mine. And so I've been trauma coordinator for 15 years, also manage emergency preparedness. So started out in Boulder.
Tell us about backcountry medicine. What is it?
Well, it's interesting to me. When I first heard about it, I was pretty skeptical. I thought, that sounds kind of niche-y. And there were a number of other people in traditional medicine who were pretty skeptical about it. But I was planning a big month-long trip up actually into the Arctic at the time, and so I was really interested. And a friend of mine I worked with was doing some work with the Student Conservation Association. That's how we got started. So basically it's taking everyday principles of emergency medicine and learning how to apply them in a wilderness backcountry situation. So it's not new medicine. It's just you already know how to deal with somebody who's bleeding or fractured or whatever, or just sick here in the front country. But what different skills, not just skills, but how differently do you need to think about either when to evacuate or when to stay and seek shelter and try to get help to come in. So think about all those variables too.
So is that something that you train people how to do then?
Yes. Yeah.
Okay.
Area backcountry medicine does, well, they've had 10,000 students, I think, over the 20 years, and
Wow.
they do courses internationally. So there's short courses like a weekend wilderness first aid, and then you can actually get a wilderness EMT.
Wow. So I assume you're a backpacker yourself.
Yeah, I do a lot of
And there's
stuff.
always that decision before you head out about what you can cut to lighten your load. That must be a harder decision for you. Is there something you throw in your pack that other people might not think to throw in there?
I would say right now a tourniquet. Afghanistan, Iraq have shown us that they used to say you'd sacrifice the limb if you put a tourniquet on for an uncontrolled extremity bleed, and only put one on if you thought that was the only way of saving the life. But they've learned that you really don't necessarily write off that limb by putting a tourniquet on. But it's a constant battle because I always want to take tons of stuff, and I'm getting old. I can't carry all that weight anymore. So it's a tough battle, but I would say a tourniquet.
That's where that daughter you have comes into play, right?
Yeah, right.
So let's talk about what happens at St. Pat's, because I think a lot of the term trauma center is thrown out quite a bit, but with various hospitals. First of all, how does a hospital get to be a trauma, especially a level 2 trauma center?
Well, there are two different mechanisms. There's a state designation, and then there's a national group, the American College of Surgeons, that verifies trauma centers. So there are different criteria that you have to meet in order to be a level 2 versus a level 3 versus a level 4. And the smaller the number, the higher level you are. So there are no level 1s in Montana. So just like we send people to Harborview if we can't handle them in Seattle. So you have to meet all these rigid standards, and there are two different ways of managing a state trauma system. And some states have an exclusive system, so they just put all their resources into the big places, like the level 1s. And then other states like Montana, since we have so many small facilities, we have what's called an inclusive system. So like places like Dillon, Superior, they're actually trauma centers, just at a different level than St. Pat's or Great Falls or Billings. And we try to do as much work with all of the facilities as we can. 35-40% of our trauma patients, and to be a trauma patient at St. Pat's, you have to be pretty significantly injured. It's not, you slid into second base and broke your ankle. We're talking about the more significantly injured people. 35 to 40% of those are seen at other facilities first. And since we're the regional trauma center, let's say something happens in Plain or Polson, they can't handle it, so then they'll send it to us. So what happens at those places is every bit as important as what happens at St. Pat's, because if they arrive late, cold, then they don't have as good a chance.
Sure.
Who makes the call on whether someone reaches the level of trauma needed to go to a 2 or needed to go to a 1, et cetera?
Well, it starts with EMS, the ambulance, helicopter people, and a lot of times it depends on how close you are to which type facility. A lot of times it depends just whether or not patient needs airway support. And then a lot of times if they go to the outlying facility, then it's the physician or PA or nurse practitioner who's manning the emergency department at that time who makes that call.
So
and it's a very difficult call sometimes.
So basically, when there's an accident or I don't know, a criminal activity or whatever, you are notified ahead of time. This is a trauma. This is not just an accident victim or whatever. That this is a trauma coming in. That's what the EMTs are letting you know ahead of time, so you can get your team together, right?
Right. We have pre-established criteria that if EMS calls in with a certain report, then there are some patients, even before we see them, and this is one of the beauties of the trauma system, is that we'll have an OR team and a surgeon there before the patient even arrives if we get advance knowledge of that patient's arrival. So that's obviously very helpful. A lot of times people just come on their own, though, and we have drive-ups, and then we have no advance warning whatsoever, and then we have to scramble.
Now, your title is Trauma Nurse Coordinator, at least part of your title
Right.
is. So what role do you play in the hospital system? I think a lot of times when I think of a nurse in a trauma, I would think the doctor would be telling people where to go and what to do. But obviously your name kind of shows that you're in charge of that. So tell us how you operate.
Actually, I don't manage the resuscitation in the emergency department. That's still physician-driven. Number one for trauma is the trauma surgeon working with the emergency room physician. I actually have a desk job now, so for 15 years I've just managed the system. So I work on, the main thing I do is performance improvement. So evaluation of the care that we rendered on any specific, actually we review every case. And then we see if there's something we could have done better, if there's lessons to be learned. Do we need new policy? Do we need education? Do we need counseling for people? Do we need to do better outreach education with outside facilities? So I do a lot of education and what we call performance improvement.
Gotcha. So you're like meta level of nursing, thinking a little bit outside the box, seeing.
Yeah, it's like I spent the first 15 years at the bedside taking care of patients, and now I spent the last 15 years working more on the system. And really it's to support the people at the bedside. It's, and a lot of the ways we find out that there are what we call opportunities for improvement is from nurses telling us, hey, this didn't work very well. Next time we need to do better on this. And it's my job to help them fix that.
I know we need to go, but when we get back, I'd really like you to kind of walk us through one of those changes that we've made, something you were able to identify and shift the way the practice worked in order to get better results.
Okay.
We also have phone lines open if you'd like to talk with John, 721-1290. And, of course, he is with Providence Health and Services, Western Montana. He's the trauma coordinator for St. Pat's. We're coming right back right after this quick time out here on Health Talk. Hey, we're back on Talkback. 721-1290 is our number. Actually, Health Talk, of course, sponsored by Providence Health and Services, Western Montana. John Bleicher, trauma coordinator, joining us in studio. And you guys were having a very animated conversation during the break.
Well, I find John's job fascinating. Being able to try, have your finger on the system and try to find out where things are wrong and what little adjustments need to be made to save more lives. It sounds fascinating, and especially with trauma, which is kind of those unique incidences. A trauma I think of anyway as, the guy step in a bear trap. The next day someone gets hit by a car. It's very different, and you don't know what to expect. So
John, does it surprise you what the human body can recover from?
Oh, absolutely. We have miracle outcomes that are just astounding.
Yeah.
Now, before the break, I asked you if you could show me the process or tell me something that you changed. You were able to locate an issue that we were having in the system and get a better outcome. I was hoping maybe you could walk through that for us.
Sure. A real good example, since it's very timely because there are so many more anticoagulants, anti-blood clotting agents on the market, is that we found through going to conferences and talking to people nationally and then through our own data that every now and then people fall and you get a minor hit on the head that you wouldn't hardly even think that much of. But if you take Coumadin or now any one of these other anticoagulants, you can actually, since the goal of those is so you don't clot, so you don't throw a blood clot, so you don't have a stroke. The problem is when you have even a small bleed in your head, you don't clot, so you keep bleeding. And so little dings on the head that normally wouldn't even have gotten our attention, we were finding were actually killing people who were taking these anticoagulants. So we changed our whole process to, we jump those people up a triage level. They get an immediate CAT scan of their head. If there's anything at all on that CAT scan, even the most minor little thing that normally we would say, oh, it's nothing, they get a stat neurosurgical consultation. They get admission to the ICU. They get their Coumadin or whatever reversed as best we can. And just because every now and then those blow up. And so that's sort of performance improvement and injury outcome prevention sort of all rolled into one.
When you say triage, I think a lot of people might think like a musical trio or something. What do you mean by a triage
Or
level?
MASH.
Yeah, there you go.
Right.
Yeah.
Triage is sorting of patients. So on the scene, if you're on a motor vehicle crash and you have 7 patients, you do triage and picking which ones need to be treated and transported first. But the emergency department's doing triage constantly. So when people come in, either by ambulance or walk-in or whatever, they'll assign a triage level, and they either go directly back to a room and get a physician immediately, or they can sit in the waiting room based on that triage level.
I was going to ask you about that, because many times when people go into an emergency room, they're placed into a room and they don't see everything else that's going on in the ER. And so sometimes when you have a boo-boo or a sprained ankle or, whatever, well, where's that doggone doctor? Why aren't they? So, what? I'm important. What's going on? So do you have to try to educate them a little bit? Or
yes, and the more time you can talk to people and try to explain the situation, the better. Right. People sometimes wait hours for treatment.
Sure.
But if someone's having a heart attack and there's 2 traumas and somebody had an overdose and someone's having a psychiatric problem, those just take priority.
Sure.
And sometimes it's just a matter of luck as to when you go in, whether you're going to be seen quickly. Now, if you have something life-threatening, you're going to get seen quickly no matter what. But everything under that level,
right,
it just depends on how busy we are with more pressing matters.
I'm really curious, Montana being a fairly rural state, if not one of the most rural states, it seems to me that, especially with trauma, the speed of getting a person care would be fundamental to getting trauma patients in and out in a healthy way. So how do we do in a state like Montana? Do we perform well in dealing with trauma, or do we have a hard time with it?
We actually don't perform well. We do well considering the circumstances. So the circumstances, a rural frontier, bad weather, a lot of it's just unavoidable. If you roll in the ditch in someplace out in the middle of nowhere, and there's a really small hospital 30 miles away, and the bigger level 2 trauma center is another hour away by air, then that's just the way it is, and you're going to have a delayed response. The other part of it, though, is there are some built-in ways that we underperform, and the number one of those is just experience. We don't see a lot, and especially the people in the smaller facilities don't see a lot of traumas every year. So it's always harder to do something well when you do it infrequently. And trauma is very complex. It's not just the trying to figure out what the injuries are. It's also trying to figure out what those injuries mean for this patient. An elderly person with heart and lung disease who's maybe obese, takes a lot of medications, needs a different level of care than someone who's 19 and healthy with the same injuries. So the weather and the time, the lack of experience, all of those things come into play. The Missoulian has nurses' notes, and I've written a number of those, and there's one coming out soon that I just wrote about how I think our state trauma system is underfunded as well. And so I think if we could get more support for rural EMS and for smaller hospitals, I think care would improve.
Where does that funding come from?
Well, right now it's the state, it's the Department of Public Health and Human Services. There's an EMS and trauma systems section. And they get some grant funding, but their actual budget works out to 15 cents per Montanan.
Wow. Okay. I guess the other question is, Do you and your staff get to go to these outlying hospitals like Mineral County or maybe in Havre or wherever where traumas happen, especially farm incidents, farm accidents, things like that, where they're a long way from Billings or Bozeman or whatever, Great Falls? Do you go out there and do training, or do they come to you?
Both. Okay. They come to us for classes, and also we have an annual trauma conference, Spring Fever, that we put on for free. This year we had 324 attendees,
Wow.
so it was great.
So what kind of things did you cover?
Pediatric trauma, geriatric trauma, sort of burnout in the profession. EMS did a bunch of practical skills. We always end the day with case reviews. So it was a really good, we had to talk on trauma systems. Mm-hmm. But then the trauma program has an outreach educator. So we have a nurse who goes out to the smaller facilities and will actually go to Dillon or Whitefish or wherever and actually put on education for them at their request.
So if there was something else that we could do, aside from waiting for the government to send more money to help with the EMS system, what sort of things can we change to improve our trauma rate or our trauma
That's a really good
outcomes?
question. Thank you for asking. There's two things you could do. Number one is pressure government to do more. So at the local legislative level, talk to local legislators about how, the problem with trauma is it's a huge problem, but it gets very little money because I think there's this sense of it's unpreventable, it's an act of God, it happens and we'll get good care, and it's actually not true. Most traumas are preventable, and you really could get better care if we had a better system. I truly believe that. The second thing you could do is just not become a trauma patient. And the way to do that is to not be impaired when you drive, wear your seatbelt, drive within the speed limit or for whatever is appropriate for the conditions at the time, and just slow down. Wearing your of all of those, wearing the seatbelt probably being the most important.
Okay, we're going to take a little break. Come right back. 721-1290 is our number, and I'm going to ask John when we come back just some success stories that he's been in the business a long time. I'd like to hear some. He's referenced a little bit of miraculous things that have gone on in his career. I'd love to hear about some of them, and we'll be right back with more of Health Talk right after this. Well, this is a place where you learn a lot on Health Talk. We certainly are today. John Bleicher joining us this morning, the retiring trauma coordinator here in the next couple of weeks, and we're glad we got you before you left.
Thank you.
It's a pleasure. Now, John, you had an interesting question that
one of the things I really wanted to get from you was a look at what Montana trauma patients, what do they look like? What are they going in there for?
So the demographic is a little different. Number one, trauma is injury. So anytime anyone's injured and not just sick. And our demographic is different than the national on two main levels. Number one, most rural states have a higher percentage of elderly than more urban communities and states. So we have a lot more elderly, so we have a lot more falls. And a fall down the flight of stairs can kill someone, especially if they're on an anticoagulant. The other thing is that our incidence of vehicular trauma is way higher than the national average. So that's partially due to people driving too fast. We have a high rate of always one of the highest rates in the country of alcoholism and driving impaired. Part of it's just our roads and our weather. And part of it's just we use vehicles for a lot. It's not just cars. It's ATVs, boats, snowmobiles, all that stuff. So a preponderance of vehicular trauma and falls.
I think a lot of people would assume gunshot wounds, that sort of thing.
Yeah, we're way under the national average for that. Really, and in hunting season, I'm always amazed at how few gunshot wounds, accidental, come out of hunting season. People are actually pretty safe. I think they've done a really good job with hunter education in this state. It's the more urban areas that have the more knife and gun club type of stuff. That's actually not a big part of what we deal with.
I hope those New Yorkers are listening right now.
So we have a minute left in the show. So can you just draw from your memory one instance where it was just an absolute miracle this person survived?
I've had a couple come to mind. A fellow had a 500-pound slab of steel fall on his chest in a workplace accident, and they were doing cardiopulmonary resuscitation, and a year and a half later, he walked the Missoula Half Marathon with his wife's assistance.
Wow.
We had another kid whose vehicle, I have a picture of his vehicle, was literally torn in half, and his girlfriend died, and he almost died on us about 3 times. And then a year later, he sent a picture of him on top of a 14,000-foot peak in Colorado. So it's people ask me, how do you do this job? It's obviously pretty depressing, and it certainly is at times. But every now and then we do have miraculous recoveries. But the healthier you are going in, the better the odds are that you'll do well on the back end.
Hey, John, best of luck in your returement.
Great, thank you.
And thank you for serving. Thank you for all the service, all the people that you've helped and ministered to over the years. I'm sure they bless your name.
Oh, well, you're very welcome. Thank
all right,
you.
thanks, John. And that's going to do it for today's edition of Health Talk. We'll do it again next week right here on KGVO 1290 AM, 101.5 FM, and newstalkkgvo.com.